Well, good morning. And I second what Jim said about sticking around for this. It really means a lot to have so many friends and colleagues and students here today, and really appreciate you all doing that, changing plans and so on. And Jim, thanks for the introduction. It's really an honor to be introduced by you, someone I've always looked up to for my whole professional career, and it's great to see you still doing the great things that you're doing, so thanks for the introduction. So obviously you know the title of my talk, but I certainly want to thank the American College of Sports Medicine for this wonderful honor of being invited to do a presidential lecture. I certainly never thought in my early days that this would ever be an opportunity that came along, so I'm really honored and really appreciative of this opportunity. But really, I'm just here to do a favor for Walt Thompson. Is Walt in here? See, that's the kind of favor you do for Walt. He asked you to do a talk, and he's not even here. So it's not going to be nearly as fun to make a joke about Walt if he's not even here. So someone can tell him if they see him that I was poking fun at him. But really, he called me in late summer last year, left a message that said, "Pete, call me back. I need you to do a favor." I was like, oh, damn, what does Walt want me to do now? Write a chapter in a book or edit something or introduce somebody at the conference? I just, was like, I don't even want to call this damn guy back. I mean, I really don't even want to talk to him. Little did I know this favor was this opportunity to present this lecture here today, and I couldn't be more happy about that, and I guess I need to keep doing favors for Walt. But the other thing is Walt encouraged me to come up with a catchy title for this, so I threw out a couple things like, nah, it's not catchy enough, nah. So I finally came up with this, which then I realized kind of backed me into the corner, because now I got to talk about HIT training and resistance training. Each one of those two could have filled up in an entire session, so I have to sort of cut it short and do half time on each of these. But these are important topics in many populations, but certainly important in our heart failure populations. The potential role of HIT training and this ever increasingly important role of resistance training in this population. So I've never done this before either, but I'm going to start with a dedication to a good friend that passed away just a couple months ago, Dr. Hiro Tanaka, who I actually met at ACS conference in 1993. So this would have been our 25th year meeting up at this conference and others. So it's kind of a bittersweet time to be here doing this without my good friend Dr. Tanaka here. I was fortunate to be able to be in Japan earlier this spring to be at his last lecture and some of those things that went on. But I met him 25 years ago. We've continued to collaborate and have a great friendship. But he was a professor at Fukuoka University, very internationally recognized guy. I imagine there's some people in the room that knew him or recognize him. He mentored hundreds of students and brought a big group every year to ACSM. He was a real supporter and proponent of ACSM. He established a very important Institute of Physical Activity at his university. Of course, he made many, many scientific contributions with publications and grants and so forth. But I think beyond that, the collaborations and friendships that he established around the globe, is just so amazing. And even though his life was cut a bit short, he certainly lived every day to its fullest. I mean, this is a guy that really did everything, was on the go all the time, never said no, and so he got a lot out of the shorter life that he had and gave a lot to so many of us. So I just wanted to pay tribute to Hiro before I started. So where are we going here with this presentation? Well, there's obviously all kinds of paths and topics we could address, but I want to give you some objectives, what I hope to think that we're going to cover, and that is to appreciate the unique pathophysiology that these heart failure patients have and how this pathophysiology affects their acute and chronic responses to exercise. So we'll talk a bit about the traditional fit approach to prescribing exercise that many of us use and many professional organizations use. But then really the focus will be on gaining appreciation for some of the potential emerging applications or emerging strategies for these patients, including the HIT training and the resistance training, which I think are many ways where things are going in the future. So there are many organizations with exercise recommendations for these heart failure patients. I'm sure you know about some of these from different societies and associations around the globe. But I'll focus on the one from the American College of Cardiology, American Heart Association. And clearly, like these other organizations around the world, exercise training is recommended for these heart failure patients as it's safe and effective. And that cardiac rehabilitation is very useful in these patients to improve their functional capacity, their quality of life, and maybe perhaps even improve their mortality. I know you all are familiar with the ACSM guidelines, and we have now the 10th edition of that, with a very nice document. And in this document, they provide the fit recommendations for those with heart failure, and focus in on the intensity here. You can see the recommendations there, which pretty much are a moderate intensity prescription for exercise for these individuals. There also is recommendations for resistance training in these patients, even though resistance training hasn't really been that widely used in these patient populations, but our own guidelines suggest that they should be. So when we really think about what's been going on with exercise prescription in heart failure patients, it's pretty safe to say that most of the studies that have been published, including the very large HF Action study that Dr. Krause was a big part of, and maybe some others in this room, have used a fairly generic approach, the sort of traditional fit approach to prescribing exercise, which includes moderate intensity exercise, 40 to 70% of the peak levels, 30 to 40 minutes of exercise, 3 to 4 times a week. Usually the studies, programs last 12 to 20 weeks. And like I said, resistance training has been, in some studies, been included, but not universally, not consistently, which I think is a missed opportunity there. So there's clearly the prevailing evidence from several decades now is that this approach, this fit approach as presented in the ACSM guidelines, is very effective and very safe and well tolerated, as there's really no evidence of untoward events and worsened outcomes. So I'm just going to quickly summarize the benefits that we've learned over the past 30 years about moderate continuous endurance exercise training in these patients. Clearly, it improves exercise tolerance. We see that consistently across many studies. Minimal improvement in cardiac function, but perhaps the best effective exercise in this realm is to prevent the undesirable deterioration of the heart, or the remodeling that goes on with heart failure. As we know, most of the benefits in this patient population is with peripheral adaptations. There's many different mechanisms that have been shown to improve very dramatically, including endothelial function, oxygen extraction, mitochondrial activity, and so many other things. And this is where really majority of the benefits that these patients get is from these peripheral adaptations. Importantly, it's been shown that it decreases the sympathetic tone, the neurohormones, some of the inflammatory cytokines and things that occur in these heart failure patients are reduced with exercise. Likewise, ventilation improves, dyspnea is reduced, and quality of life and symptoms get better. We know from HF Action and some other studies that moderate continuous exercise training does result in moderate reduction in morbidity and mortality. And most importantly, there's really been no reports of adverse events in this approach. So you might ask, and back to Jim's Southern thing, if it ain't broke, why fix it? Right? So we could be looking at how we've been prescribing exercise, what we've been doing for the past 3 decades, and say, well, you just told us that it works really well, it's great, why would we fix it? So we could certainly take this approach and just sort of bury our heads and say, what we're doing works, and why would we do anything differently? Or we could question whether perhaps there's a better approach that we should be considering. This clicker clicks every 2 times. So very nice working group at NHLBI. Got together a couple years ago and put together a document on the current status and future directions of exercise training for heart failure patients. And you'll recognize many of the names, including Dr. Krause and probably some others in the room. But they identified some really important key knowledge gaps. And one of those was, what is the optimal training intensity for these heart failure patients? Is it high intensity? Is it moderate continuous training? Should it be whole body exercise versus small muscle mass or resistance training? So they asked some very important questions in this document and things that we haven't quite answered yet. And also bring up the issue there related to understanding this in both the HFrEF and HFpEF patients. So if you don't know much about heart failure, you may not be too familiar with those, but I'll try to explain that briefly, because we now know there's 2 main phenotypes for heart failure. In fact, this is a picture that might help you understand that a little bit if you don't know it already. We know that there are these two phenotypes now, one with a very large heart that doesn't pump out very well, one with a very small heart that doesn't relax very well. In the end, these two hearts produce really the same constellation of symptoms and syndrome that occurs. And this is all because both of these hearts, especially under exertion, don't put out adequate cardiac output to meet the needs of the body. And we and others have shown that this syndrome occurs equally, almost the same magnitude in HFpEF as it does in the HFrEF population. So this lack of cardiac output then leads to lack of blood supply to around the body, which results in pulmonary mismatching and a lot of the ventilatory abnormalities that we see. Is also lack of blood supply to the kidneys, which in turn activates a variety of neurohormonal systems in the body. And these neurohormones then cause a lot of adaptations within the peripheral physiology, including vasoconstriction and reduced blood supply to the skeletal muscle. And that's going to be an important theme for where we go in the rest of this, this talk. So that lack of blood supply to the skeletal muscle causes a lot of skeletal muscle dysfunction. So I'll explain some of that briefly. And this is the main contributor, the main cause of the exercise intolerance that we know exists in these heart failure patients. So we're going to really kind of focus in on this skeletal muscle dysfunction because it really is a very critical part of this syndrome that we call heart failure. So it's been shown over many years now, decades, that the skeletal muscle of these heart failure patients, when I'm talking specifically about those with a reduced ejection fraction, at this point we're starting to learn more about those with a preserved ejection fraction, but clearly there's a reduction in oxidative enzymes in the muscle, decrease in the mitochondrial volume and density, an increase in the non-oxidative enzymes. So these muscle fibers really shift as a result of that poor blood supply because of the failing heart. The muscle atrophies in general, and there is this shifting of these muscle fiber types and characteristics that go on within these patients. So we know there's a lot of problems, a lot of abnormalities going in there. So given that, perhaps that gives us a reason to challenge this traditional approach to prescribing exercise the way we've been doing with this moderate, continuous approach, given this unique pathophysiology in their muscle. So perhaps we're looking at a new paradigm ahead and shifting our thinking on this. Which brings us to HIT. So as many in this room know, HIT is a very hot topic. Everybody's interested in HIT right now, right? And in fact, the Acsm Health and Fitness Journal, which comes out every year with the worldwide fitness trends, has HIT as the number one fitness trend or interest. And of course, there's lots of lay literature about this. Why HIT? Well, it burns more fat, increases stamina, it revs up your metabolism. Shorter workouts, which could be potentially appealing. Don't get bored. So lots of benefits there. Now, HIT training's been used in a lot of populations. It's definitely made its way into the clinical setting. I don't have time to go through all the studies that have done this in different populations, but it's been shown in really well done studies that HIT training can have a very positive influence on many different cardiovascular risk factors. This has been shown in quite a large amount of literature. In fact, some of the studies have shown that HIT actually produces superior physical, clinical, and functional benefits to the moderate intensity exercise, and raises the question, should HIT be utilized more broadly in our clinical populations? There's good evidence to support that this exists. So if we agree that HIT is effective in our cardiovascular disease patients for prevention and rehabilitation, the next question, of course, is it safe? Is it safe for these patients to do that? And a large retrospective study out of Norway of almost 5,000 patients participating in their cardiac rehab programs around the country found the patients completed an average of 37 exercise sessions. Most of them were moderate continuous training, but they were beginning to use HIT more and more. So there was people doing HIT training as well. And what you can see here in this slide is that moderate intensity training in these almost 5,000 patients resulted in one cardiac arrest that was fatal. High intensity interval training, although there was less of it, there was 2 events, but they were both non-fatal. So this study concludes that the risk of cardiovascular events is very low in both high intensity interval training and moderate continuous training in this cardiovascular rehab setting. So these authors would suggest then that HIT is safe and should be considered for our rehabilitation of our CVD patients. Also assessing safety was a meta-analysis that was published just recently. I think it came out of France, I think, or no, it was, well, I don't remember where it's from. Anyway, but they looked at an updated review and a meta-analysis looking at some of the secondary outcomes related to aerobic interval training versus continuous training in CAD patients and heart failure patients. And there was 18 studies, 775 patients, and really found that in this meta-analysis there was very few adverse events that were reported. In fact, only 3 adverse events, and they were all in a large Hiit trial that I'm going to talk about from Europe. And one study had a report of dizziness. So in these fairly large number of studies and large number of patients, there's been very few significant events during exercise. To my knowledge, one of the first Hiit studies that was, it wasn't called Hiit at the time per se, but in heart failure patients was done in Germany by Katrine Mayer. And they did a baseline test on their heart failure patients. These were all HFrEF patients, and then had them exercise in these bouts that at the time, these were 30-second bouts of exercise followed by 60 seconds of recovery. The recovery was only 15 watts. So they did 10 bouts in 15 minutes, a very short, fairly intense type of exercise. And they did this for 5 days a week, and they also did some treadmill walking in addition to that. What they found, there was no complications, very high compliance, but this is only a 3-week study. This was a very short-term study, but yet it was well adhered to and safe. The intervals that these patients did over the course of 3 weeks, the first week on average they were at 72 watts, then they went up to 86 watts, and then they were at 100 watts for their intervals in the 3rd week of the training, which if you know heart failure patients, you know that's a pretty high level of work. Interestingly, they found that the cardiac stress measured by just the rate pressure product, and they measured some catecholamines during these really high work levels, these really high interval levels, that the cardiac stress was only comparable to about 75% of the stress that was seen on the standard ramp initial baseline test, but these patients were at twice the workload, and yet the cardiac stress was actually less. What they found was that the VO2 increased dramatically, 20% increase in 3 weeks. As you might know, that's a very dramatic change over that short period of time, particularly. So they concluded that this type of training allows for this very intense stimulation of the peripheral muscle with minimal cardiac strain, and that this may be necessary to reverse these skeletal muscle abnormalities that I described earlier. So this to me was the first time that this was taught, and hard to believe this is 20 years ago now. And then we're talking about this as a hot new topic, right? But 20 years ago, Dr. Meyer and colleagues was doing this already in heart failure patients in Germany. Probably the most widely cited paper for good reasons comes from Dr. Wisloff, who many of you know in this room, and they published a very seminal paper in 2007. Again, hard to believe that's been 10 years ago already, but they had a relatively small number of people, 27 patients, but they all had HFrEF, they had the reduced ejection fraction, older adults, and they were randomized to 3 different groups, right? The control group, a moderate continuous training group, and an aerobic interval training group. And you can see the moderate continuous group did very traditional, 70% of peak for average 47 minutes for their workout. The high intensity interval group did 95% of peak heart rate. 95% of peak heart rate for 4 minutes, followed by 3-minute active pauses for a shorter period of time, in part to keep the caloric expenditure relatively the same. It was a 12-week study, did the exercise for 3 times a week. 2 of those were supervised, 1 was not, on treadmills and over ground walking. And many of you may be familiar with these results, but we look at endothelial function with the 3 groups, control, moderate continuous, aerobic. You see, of course, there was no improvement in the control group. Moderate continuous and the aerobic groups both had significant increases in their improvements in their endothelial function. And then when you look at maximal oxygen consumption, this clicker is like getting tired. You can see that both groups also had significant improvements in their VO2, but the high intensity interval group clearly had a more dramatic magnitude change in their VO2. And then some of the secondary outcomes that they looked at included measures of mitochondrial biogenesis, and you can see the aerobic interval group was the only one that significantly improved that. Likewise, for this very important neurohormone pro-BNP, it's a very important prognostic neurohormone. You can see the only group that had a reduction in that was the aerobic interval training group, and then some others such as oxidized LDL, one of the measures of sarcoplasmic reticulum handling of calcium, total oxidative status. The aerobic interval training group was the only one that improved significantly in those measures as well. So Dr. Wisloff and his colleagues concluded at the time that in HFrEF patients that aerobic interval training was better than moderate continuous training. My good friend and colleague that was here earlier in the week but left, Mark Hakowski, did a meta-analysis looking at aerobic interval training versus the continuous intensity, moderate intensity training, and reviewed at that time in 2013 a handful or so of studies. And you can see that if you look at the 7 studies that are reported there, looking at whether moderate continuous versus high intensity related to VO2, you can see that there were several studies that were neutral, but at least 4 of the studies, including Dr. Wisloff's study, that showed clearly that the high intensity interval training had a more favorable effect on this particular measure of VO2. They also looked at left ventricular ejection fraction, and here you see there really was no significant difference between the moderate continuous versus the HIT. The good news is that the HIT clearly didn't make left ventricular ejection fraction worse, which is always one of the concerns about this kind of a training with these patients with these diseased hearts, failing hearts. But clearly this showed that there was no concern with that, and if anything, maybe a slight improvement relative to the moderate continuous training. To my knowledge, the only study that has done HIT training in the heart failure preserved ejection fraction is Sid Angadi and Glenn Gazer from Arizona State, and Sid's sitting up there in the back. It's always funny to talk about somebody else's studies when they're here. But that, to my knowledge, was the only study that used this HIT approach. They did the same 4x4 high-intensity interval training versus a very traditional moderate continuous of at 70%, and looked at this relative to the outcomes of FMD, VO2 peak, and diastolic function or diastolic dysfunction in these HFpEF patients. What they found was that the HIT significantly increased the VO2, an average of 9%, and also tended to improve some of the diastolic function measurements of these patients. In fact, 6 of the 9 subjects in their HIT group actually showed improvement in their diastolic function. So they improved some of the relaxation capabilities of the heart, and that's certainly important in these patients. So taking Sid's words directly, there was significant improvement in VO2 peak and diastolic function in just 4 weeks of HIT training. And that these degrees of improvement are very consistent with what we and so many others have shown to occur with the moderate intensity type program, but over a longer duration. So they showed the same benefits in a much shorter period of time. And importantly, this was well tolerated by the patients in this study, who were mostly older, obese, and so on. So this was, to my knowledge, the first and only evidence about the impact and the safety of HIT training in HFpEF patients. We definitely have learned a lot more recently related to HIT training because of a large trial that was conducted in Europe called the Controlled Study of Myocardial Recovery After Interval Training, called SMART-HF. This was 7 centers throughout Europe, 260 plus patients, randomized. They all had HFrEF, reduced ejection fraction, randomized either into a HIT training group, a moderate continuous training, or a recommended regular exercise group. I'll explain what these are in a moment. Primary aim was looking at left ventricular diastolic diameter to see if there was improvement in that realm, and then secondary aims included VO2 peak and biomarkers and many other things. The intervention was 12 weeks, but they had, of course, a baseline assessment, a 12-week assessment, and a 1-year follow-up assessment to look at the residual effects of these 2 types of training intervention. Up front, they recognized they were underpowered, really look at the safety differences between these 2, so they really couldn't address that well. But these were HFrEF patients, again, randomized to these 3 groups. The HIT and the MCT had 3 extra supervised sessions per week on a treadmill or a bike for 12 weeks. The HIT was the 4x4 approach, aimed at 90 to 95% of max heart rate. And the HIT sessions lasted on average 38 minutes. The moderate continuous sessions aimed at 60 to 70% of that max heart rate for 45 minutes. The RRE subjects were advised to exercise at home. Of course, we know what patients do with that recommendation, right? They don't do much with it. But they also were asked to attend 1 MCT session every few weeks just to keep them, engaged in the study. They assessed the important outcomes. Baseline, they had 247 patients at the 12-week follow-up. They had 215. And then by the 52, they had 202, which is still pretty good retention for a study of this large and done at multiple centers around the country. Now here's the results. It's a bit of a busy table, so let me try to walk you through this. We have baseline to 12-week results. We got baseline to 52-week results. And then we got these 3 different groups, comparisons of 3 different groups. So when you look at HIT versus RRE or MCT versus RRE over there, we can focus on really a couple of these, and that is the VO2 peak, which we see increased significantly in both the HIT and the MCT groups. Fairly similar magnitude of change there. We looked at, when they looked at end diastolic diameter, found that both groups improved reduced their end diastolic diameter, but the only significant finding was in the HIT group. Was the only one that had a significant reduction in left ventricular end diastolic diameter. That was the first 12 weeks. That's the good news. The bad news is, by 52 weeks, no difference with the HIT groups, the MCT groups, and the RRE groups. So whatever they gained in those first 12 weeks, they essentially had lost in the remainder of the year. Now, the most interesting part of the study, I think what everybody really wanted to see was what about the difference between those 2 groups head to head, right? And here we see the results there. And as you note, there are no significant differences between the groups at 12 weeks for their cardiac function, for their VO2, for this important neurohormone. No significant difference between these 2 approaches. Of course, then, that same finding existed at 52 weeks. We wouldn't think then all of a sudden there'd be some probably dramatic improvement in one group versus the other, later in that same year. So this trial was important in a lot of ways and concluded that high-intensity interval training was not superior to moderate continuous training. Even when you do this in supervised centers, people that cardiac rehabilitation centers. And so they concluded that moderate continuous training remains the standard exercise modality for patients with chronic heart failure. Well, I'm not sure how many people saw this, but Dr. Wisloff didn't like these findings too much and wrote a very appropriate response letter to the journal related to the findings of SMART-HF. And I think others have picked up on the same theme, but the majority of the SMART-HF participants that were randomly assigned to these groups actually didn't do what they were prescribed to do. So if we look at the right panel, the HIT group, I'm not sure how you can see the dark lines. The HIT group should have been training here at 90%, right? That's where they should have been. Well, in reality, there were some people there, but look how many people were not approaching that 90%. In fact, 62 of the 77 patients in HIT weren't actually doing HIT. They were doing a lower intensity version of HIT, right? So that's a concern. Likewise, the moderate continuous training group, you see over here, that should have been exercising at 60 to 70%, that's the black lines. Well, look, my clicker will work. Look how many people were exercising above that, right? So there were 33, almost half of the people that were exercising at too high of an intensity to what they were supposed to do. So this is a big problem for this study. Obviously, people weren't training with what they were supposed to be doing. So Dr. Wisloff's conclusion of this in his letter then was that the conclusion that HIT was not superior to moderate continuous training should be interpreted very cautiously because SMART-HF actually did not succeed in comparing these 2 groups sufficiently, and reminded us who do these kind of programs that a successful HIT program is several key things, and that is ensuring that the training intensity that's prescribed is actually what's being performed, right? Because in SMART HF, in a lot of cases, that wasn't occurring. And that we need to be checking workloads and whatnot to see if people are actually progressing the way we expect them to, the way we think they should be improving. So we learned a lot from SMART HF, and in part how challenging this is to do, how difficult this can be done to do this, even in very experienced cardiac rehab programs. So there are a lot of practical challenges, I would say, then, with using HIT in our heart failure patients. One is this problem with our patients not following instructions. Pretty much whatever we tell them to do, they often don't follow it. And certainly that becomes even more challenging with HIT. And if you're going to do this, it's going to require a lot of staff time and energy to focus one-on-one with these patients in order to really get the desired outcomes that you're looking for. Some of our folks just aren't going to be able to attain and maintain these high workloads. It might work for some, might be willing and able to do this. Others, are not going to. How are we going to control the intensity? Right? Some programs don't even do baseline exercise testing to have any data to work with. But are you going to use heart rate, RPE, work rates? There's a lot of questions about how is this intensity going to be, regulated. As I mentioned, we're going to, most likely require really motivated, perhaps very carefully selected patients, medically stable patients. I think an area we haven't investigated much is the active versus passive recoveries. What do you do in between these HIT intervals? What do you do in between? Is it passive? Is it active? What percent of their intensity should they be performing those at? It certainly makes sense, I think, to start people mainly with moderate continuous training, these heart failure patients, and then over time, if they're tolerating that well and seem to like exercise and want more of a challenge, then to progress them to some HIT sessions. That might be better accepted and tolerated by our patients. And I think a lot of us are already doing this circuit training, but this could be a very effective way of incorporating HIT training along with some resistance training, which I'm going to get to here shortly, as a way of getting this into our programs and doing HIT as well as resistance training. So I'll make some conclusions about HIT, and then we'll go on and talk about resistance training in the 15 minutes or so that we have left. I think it's pretty safe to say, and hopefully I've given you enough evidence to buy into that traditional moderate continuous training in stable heart failure patients is beneficial. There's no doubt about it. So I think we have to be a little bit careful that we don't throw the baby out with the bathwater just yet, right? That moderate continuous works, especially if we get patients to do it and do it consistently. So let's not get rid of something that's good just because there's a new hot topic that's around, right? However, with that said, there definitely are some physiological adaptations that would be perhaps better elicited by these high intensity intervals. And I think this is especially true in this heart failure population. It has this unique pathophysiology with their muscle and limited cardiac output going to that muscle. It certainly makes sense to focus on the smaller muscle mass and really try to increase the stimulus to that tissue when there's limited blood flow to, you don't want to distribute to the whole body. You want to have it go to this area that's in most need. So HIT appears to be safe. It seems to be beneficial, at least in the short term. So there's nothing wrong with it, but obviously we need a lot more studies to be done. What's the optimal HIT protocol? Most have used the 4x4, but is that the optimal? Should we use shorter ones like Maureen and her group uses in this population? I don't think we've done enough of that yet. Long-term adherence, right? I mean, can we get people to do it for 12 weeks, but can they do it for literally years if we want them to? No idea about the impact on morbidity and mortality of this kind of training, right? We're going to need more studies to see if does this really move the needle on some of these other important outcomes besides just fitness. I mean, fitness is important, but is it going to move the needle on some other outcomes? Pause there and take a little sip of water. So, lots of benefits of exercising our heart failure patients, no doubt about it. Perhaps one of the most important ones is this need to reverse this skeletal muscle myopathy that clearly exists in these patients. And this is where resistance training comes into the mix, right? So what is the role of resistance training for these heart failure patients? Certainly a good rationale for why we should be doing this. That should be pretty evident. Take care of my friend Sam. This is my buddy Sam. So skeletal muscle pathology for any of us impedes our ability to do activities of daily living. And endurance exercise training is good, improves endurance, but it's not going to have a big impact necessarily on strength and lean mass and some of these things that are really limiting to these patients. And of course, that's where resistance training comes into play to try to reverse some of that, and including our elderly patients. Many of our heart failure patients are elderly, and we know in particular that population benefits tremendously from resistance training. So, but in addition to aging, it may help address some of this muscle pathology. But I think it's safe to say that despite potential benefits, there's been some reluctance to use resistance training in heart failure patients. I think that's been around for a while, although hopefully that's changing. But the concerns obviously is that this resistance training perhaps is going to make their left ventricular function get worse. Right? That's been the sort of prevailing concern for many years. So why is there resistance to weight training in our heart failure patients from the medical perspective? Well, you think about it, you have a heart that looks like one of these, perhaps there would be some concern and problems with the potential stress that resistance training may cause. We know that exercise training has effects on the heart, structurally and functionally and geometry. And endurance training has some effects on heart structure and function. So does resistance training. The concern about resistance training is, of course, maybe this pressure overload might cause concentric hypertrophy and might possibly make this situation worse. At least that's is the potential concern. Mark Hakowski did another meta-analysis quite a while ago now, but reported that strength training was actually not associated with benefits in LV remodeling. In fact, the favorable anti-remodeling effects of aerobic exercise was not confirmed when this mode of when that aerobic exercise was combined with strength training. So looked in that meta-analysis, perhaps that strength training kind of wiped out the benefit that was seen in terms of cardiac structure and function with endurance training alone. And maybe, these are his words, but maybe the pressure loading might be the cause of that. Okay, but that was a meta-analysis. So there's been a handful of trials over the years of strength training in heart failure patients, but going back as early as 2002, I think some of the really nice work that came out of France, and that is they began doing resistance training. Now this was combined with some other modalities, but it was patients who had been discharged with a low ejection fraction, had some pretty low ejection fraction patients, 15%, but 3 one-hour sessions per week for 6 months. The resistance training was kind of the standard, 6 different exercises across the body, 60 to 80% of 10 repetition max, 3 sets of 15 with 1-minute reps. And again, it was confounded a little bit by the fact that these folks did some endurance training, and also in reality they perhaps did some HIIT training, because they described that they did some cycling that was alternating between 50 and 75% of their peak. So maybe there was a little bit of HIIT training mixed in there as well. But I think at that time that was really acceptable to do a multimodal study and not just do resistance only because of these potential concerns. So what they found in this early work was really no change in the body weight or composition per se, improvements in New York Heart Association class. Interestingly, VO2 increased significantly, but was that because of the resistance training or the other endurance component that they did? Slight improvement in left ventricular function, certainly no evidence of worsening, which was important. Strength increased, endurance increased as we would expect. And they concluded appropriately that resistance training was safe and beneficial for these heart failure patients. They followed this study up then several years later with a really nice study that actually separated out the modalities of training. So in this study, they recruited patients and randomized them to just endurance training at a very standard prescription, just strength training, 10 exercises throughout the body, and then they did a circuit training where they actually combined those two and appropriate durations, for each. And this was all done in HFrEF patients, by the way. And they did a total of 40 sessions, doing this about 3 times a week was the length of their study. They did echocardiography to look at ejection fraction, and you can see these patients all started out with a very low ejection fraction on average, right below 25. But all three exercise groups actually had significant improvements in their ejection fraction, and of course no change in the control. The greatest improvement was seen in the endurance training group, and that might be what we might have hypothesized or expected given this potential negating effect of strength training. So that was not surprising. Likewise, the VO2 peak was low, right, down around 14 mils, which is where a lot of these heart failure patients are. But again, all three training groups improved their VO2 peak. And surprisingly, the strength training group only had the greatest improvement in VO2 peak. So that was an interesting finding that we probably wouldn't have been expected. And then they looked at thigh muscle volume. They did CTs of the thigh and look at the muscle volume change and such, and you can see that in all three training groups, there was significant increase, significant increase in their thigh muscle volume. And notably, the control group had a pretty dramatic loss in thigh muscle in just 12 weeks. That's how quickly I think some of this peripheral pathology can occur. So they concluded that strength training, endurance training, and circuit training produced significant and similar improvements in these outcomes. So that was an interesting finding. Now, there was also a very recent meta-analysis that came from Brazil. It was a systematic review meta-analysis, and found that resistance exercise enhances oxygen uptake without worsening cardiac function. So this was a meta-analysis of a handful of studies that did resistance training only in HFrEF patients. And you can see that there was this very consistent, significant improvement in VO2 peak with just strength training alone, because these patients have such severe skeletal muscle pathology, weakness that becomes very limiting in their ability to do exertion and exercise. And likewise, despite one study, there was no evidence of any worsening. There was no evidence of any worsening of left ventricular function, ejection fraction. In fact, if anything, in 3 of the 4 studies actually improved with resistance training. So they therefore concluded that resistance training, either alone or in combination with aerobic exercise, is effective in our HFrEF patients and does have, certainly, if nothing else, a positive effect on VO2 peak, which a lot of us wouldn't normally have expected that. And they also went on to say resistance training is an effective option to minimize cardiac remodeling. So the fact that they were able to not see a worsening, in fact, maybe somewhat of an improvement in ejection fraction, gave some support to this may actually be beneficial. And certainly there was no adverse events in any of the patients in any of the studies that were reported. So if you're looking for recommendations on how to prescribe resistance training in heart failure patients, I think a really nice place to look is the position statement from the Heart Failure Association along with the European Association of Cardiac Rehab. And they give us some nice recommendations of how to implement this resistance training in our heart failure patients, which, I think describes this pretty nicely of a pre-training kind of approach and what you would do initially with that, a second step to begin to increase more of the muscle involvement, and then the third step really to focus on enhancing this muscle strength and muscle mass. So a nice paper there that describes not only resistance training but other modalities of training for prescribing exercise. What about resistance training in these older HFpEF patients? And to my knowledge, there's no publications to date on this, at least I'm not familiar with any. By the way, that was Walt Thompson's baby picture. I was able to dig back in the archives and find, but it does look like Walt, right? I've seen Walt make that face before. See, it's not good when he's not here. It works much better if he was here. But there's no question that this is important in the HFpEF patients, even though it hasn't been well studied. We've done several studies now and looked at the role of lean body mass and how that affects aerobic capacity and physical function in these HFpEF patients. So we know there's deficits there. In fact, when you look at our data, age-matched healthy controls relative to our HFpEF patients, clearly a significant reduction in VO2 in the HFpEF patients. And that reduction persists despite adjusting for body mass, adjusting for lean body mass, and adjusting for leg lean body mass. So even when you make those adjustments, there is still this difference between our healthy older adults and our older HFpEF patients. And this leg lean mass, percent leg lean mass, is highly related to peak VO2. We know this is important for these patients. So these older HFpEF patients have this reduced lean mass and leg lean mass, and that clearly impacts their functional levels. The decrease in peak VO2, even when indexed to lean body mass, suggests that there are, in fact, abnormalities in skeletal muscle structure and function, and this contributes largely to their exercise intolerance. So our group and others have begun to look more closely at what's going on in the skeletal muscle of these HFpEF patients, and to no great surprise, we're finding that it's virtually identical to what has already been shown to be occurring in the HFrEF patients. And I'm not going to go through this whole list, but safe to say that essentially everything that's been shown already in HFpEF patients that have gone wrong in the skeletal muscle is happening as well in the HFpEF patients. That's some of our preliminary findings as we get more and more into this area, because this is really the critical place. And in addition to a lot of those findings, we're also finding a very high prevalence of sarcopenic obesity in our HFpEF patients. And if you don't know much about that already, these are MRIs of the thigh, cross-section of the thigh. And this is a healthy older subject. Here's a older HFpEF patient. And you obviously see some color differences, right? Well, what's happening is that these HFpEF patients are losing skeletal muscle. You see how that volume has gone down. But notice that it's being replaced by intramuscular fat. So not only are they losing the muscle, it's being replaced by fat. And we know that fat has a lot of negative consequences to the function of that muscle and the function of these individuals. So this is a big problem. We know this is growing. In fact, people are now talking about the HFpEF obesity phenotype. Specifically not just that these people have heart failure, but they also have obesity, and those two things together are problematic. We find, as I'm sure others do, that 80% of our HFpEF patients are overweight and obese. And this is certainly contributing to the problems that we see there. We know obesity affects virtually all systems of the body, right? Particularly including the heart. And when it affects all systems in the heart, there's worsening of heart failure classification, reduced exercise capacity, worse quality of life. And sadly enough, majority of clinical trials have excluded these obese, overweight subjects. So we don't have a lot of knowledge really about how these people respond to exercise interventions. So the good news is I can reveal a secret to you today. I can tell you a very important secret. SECRET stands for Study Examining Caloric Restriction and Exercise Training in HFpEF patients. So this is what we're calling our new series of studies that we're doing, and we're very interested in looking at the effects of calorically restricted diets in these patients, since obesity is such a prevalent problem. And what's the role of endurance exercise training in the light of a calorically restricted diet, as well as resistance training in these HFpEF patients. So this is clearly the direction that we are going with this. So we can report on the findings of the first study. The SECRET-1 study was published a couple years ago in JAMA, where we looked at the effects of caloric restriction and really should be or aerobic exercise training on peak oxygen consumption and quality of life in these older, obese HFpEF patients. So for this study, we randomized 100 older, overweight HFpEF patients to 4 groups: attention control, an aerobic exercise training only, a caloric restricted diet only, or aerobic exercise training plus the caloric restricted diet. I'm just going to quickly summarize because I'm running out of time, but older, obese HFpEF patients that we induce an intentional weight loss via caloric restriction, we found, and this is the first study to do this, it was safe, it was feasible, and it significantly increased our co-primary outcome of VO2 peak. So clearly, caloric restriction in these older obese patients was clearly beneficial in and of itself. Now, when you combined it with aerobic exercise, then you get the most robust increase. That group, the combination of caloric restricted diet and weight loss, with that, of course, and aerobic exercise training increases exercise capacity by 2.5 mils, which is very significant, and improve their quality of life. So in addition to these These outcome measures, of course, the intent of this study was to induce weight loss, and you can see that all 4 groups listed over here, the amount of weight or mass that was lost, total mass, fat mass, lean mass. Okay, so when we look at just the total mass, the aerobic training plus the caloric restriction, in addition to these outcomes, also had the most favorable weight loss, about 24 pounds. A very large percentage of this, of course, was total fat mass, which is what we hope to occur. But unfortunately, and this has been shown certainly in many other populations, that this level of weight loss also results in a pretty significant, a large amount of lean mass, loss of lean mass. So in fact, about 30% of the total weight loss, even in those that were doing aerobic training, 30% of it, 30% of the loss was in fact in lean mass. So this is why we're now in the midst of our Secret 2 study, about halfway through Secret 2, which is looking at really just 2 groups, the group that did so well in Secret 1, caloric restriction plus aerobic training, but what we're adding to that second group now is resistance training. So we're doing resistance training in addition to these other interventions in these older HFpEF patients with the hopes that we can attenuate the loss of this very important lean mass. So we'll see. We'll have to wait for a later date to talk about the outcomes from Secret 2. So let me just make a couple conclusions here as we go over time by a minute or two. Clearly, both HFrEF and HFpEF patients have impairment in their skeletal muscle function. There's no doubt about that. And this affects their physical function, quality of life, and just about everything else. This sarcopenic obesity is a big problem. It's certainly contributing and exacerbating the problems that they have from their heart failure already. And a lot of work to be done here. Right? Resistance training looks to be beneficial and whatnot and safe, but still, what's optimal? What about long-term adherence and consequences of people doing this for long periods of time? What about this weight loss that we're doing, and how does that affect skeletal muscle? And what more understanding about what resistance training might be able to do? And then, of course, what's the impact of resistance training on other important outcomes in these patients, including morbidity and mortality? So we got a lot to learn yet. So that's good news for all of us to keep working in this area. But hopefully I've convinced you that resistance training is really critical in these particular heart failure patients. I'd be very remiss not to thank colleagues and former students, some of which are here today. I'm really honored that some students will be here. But these are people that have worked in this heart failure space that we've done. I had some really great early mentors that got me excited and interested in heart failure, and then been able to collaborate with many great people around the globe. But certainly would be very remiss not to recognize my real strongest colleague and partner in most of these studies, Delaney Kitzman, at my institution. And of course, we all know the importance of graduate students and how important they are. And these are just some of the grad students that were involved in the heart failure efforts of our team, and greatly appreciate what they've done to us. And so I'm going to close there. I want to thank you all for sticking it out to the bitter end. And I also want to thank the American College of Sports Medicine, Walt Thompson in particular, for this opportunity to be here to give a president's lecture.
Thank you. I told you it would be worthwhile staying here. On behalf of the American College of Sports Medicine, we have a little bit of a present here
Nice.
for you to take back
Okay. Thank you.
to Wake Forest.
Thank you very much.
And now,